Thank you. We move to the next session. And this is the session on ISR management, drug-eluting balloon versus stenting. And we are privileged to have international speakers and Professor Mohit Gupta, who's from Pant, and Dr. Sandeep Basavarajaiah from UK. I invite our referees and scorers, the chairpersons and moderator, Dr. Rohit Mathur, Dr. Amol Agrawal, Dr. Sibashish Sahu, Dr. Rishikesh, Dr. Jayesh Mania, and Dr. Girish Bachav to take over. Over to chair to introduce the speaker and then the session.
Thank you, Dr. Kamal. I am Dr. Rohit Mathur speaking. Good morning to everybody.
Good morning.
So we are going pretty much in time, and thanks to Dr. Kamal and everybody for organizing such a successful conference. So we are here at Bout 23. So this session is about management of in-stent restenosis with the drug-eluting balloon or stenting. And let me summarize the case. This is a 72-year-old male who is post-CABG 7 years back, and he has presented with non-STEMI. His angiogram shows a patent LIMA to LAD with a 90% ISR in previously stented proximal SVG to OM graft. The size of the stent was 4.5 into 38. It was 6 months back, and the territory is viable. Now the debate is to whether manage it with the drug-eluting balloon or manage it with stent. So let me invite first Dr. Sandeep Basavarajaiah, and he will be debating this with his side being on drug-eluting balloon. Dr. Sandeep, over to you.
Good morning, everyone. Can you all see my screen?
Yes, sir.
Okay, thank you. So good morning, and for us it's very early morning, 5 o'clock. So thank you for the invite for this very prestigious meeting, and congratulations to Kamal and his team for putting this up, especially in this crisis time, which has affected everyone globally. So I'm a cardiologist in Heartlands Hospital in Birmingham, and in this debate, I'll be participating on management of this patient who is a 72-year-old man with NSTEMI, with a background of CABG 7 years ago. He had an angioplasty to vein graft up to his marginal 6 months ago, and now he has come back with a 90% restenosis, and the presentation is acute coronary syndrome. So what are the management options? I think we've got 4 options here. Number 1, you could use a drug-coated balloon. Number 2, you can place another stent. Number 3, you can ignore the vein graft and treat the native vessel. And 4, you can go for a medical management. Because the patient has come with the ACS, I think everyone agrees that medical management is not in the best interest for the patient. So how do we choose the other 3 options? Now, what's the best option? From my point of view, the best option is treating the native vessel. And why do I say this? What's the rationale? The rationale is that we need to know some facts about the vein grafts. Patents of the vein graft at 10 years is 50 to 60%. And even if they are patent, they tend to have degenerative changes. And once they start misbehaving, the long-term patency is very low. For example, this patient has restenosis, and the long-term patency of this vein graft is very, very low. So PCI to native vessel has a better outcome as compared to PCI to vein grafts. And this has been demonstrated in a paper by Emmanuel Brilakis from United States, where they've compared the native cohort for PCI in 73% of patients and compared with the vein graft, and the outcome at the long-term outcome for death, MI, or revascularization clearly shows that patients who had a PCI to the native vessel, that's in red, have done better compared to patients who had PCI to their vein grafts. And if I show you an example from our center, so this patient had a vein graft to the right coronary artery, and the native RCA is blocked. He comes in with acute ST elevation MI. So obviously we first establish the flow in the vein graft, which is very degenerated, as you can see, very ectatic, and the lesion is here as a culprit. So we just balloon this, establish the flow, patient, the pain gets better, we give him GP2B3 inhibitors, and then he was sent home, and we brought him back 4 weeks later and opened the native RCA because we knew that the vein graft will not stay for long. So we basically gone with the Corsair and Gladius wire, anti-grade knuckling. And then we came back retroactively through the vein graft. While it's open, we took the opportunity and went back with the Corsair and again a Gladius wire. We perform a reverse card by ballooning, and connecting the two space, and you could see the retrograde wire going into the antegrade guide. Essentially, we had a very nice result where we opened the native RCA. So in my opinion, the first option should be treating the native vessel. It's better than vein graft. But let's say if you don't have that option, so either you can't open the artery because of anatomical problems, or if you don't have an expertise to open the native circumflex obviously here, then the next best option is to go for a DCB. And the reason why I say that is because we now have enough evidence in the literature. And more importantly, we have the ESC guidelines in 2014 and 2018, which have recommended DCB as the first line of treatment for patients with bare metal and drug-eluting stent restenosis. So we have a backup or backing up from the guidelines. What is the rationale? The rationale is to avoid another layer of metal, especially if there's a mechanical issue with the stent. Now, this trial by Gary Mint's group, published a few years ago, shows that when they analyzed around 74 patients with restenosis in the vein graft, approximately 33% of them had a mechanical problem, that is under expansion or a fracture. So bearing this in mind, we have to have a very low threshold for using an intravascular ultrasound for management of restenosis before implanting a stent or a DCB. Again, if I show this case, this is of a native vessel, a patient who had a circumflex stent with a 3 millimeter drug-eluting stent a few years ago, comes back with the restenosis. Now, when I ask anyone in the audience or my previous experience in presenting this case, what would one do? I would say, I will take a 3.5 millimeter NC balloon and then I use a DCB. That's what the answer I get. But when you do an IVUS, what you see is a significant under-expansion of the undersizing of the stent. It's a huge vessel. If you look at the distal reference diameter, it was 4.5, and proximally the vessel is 5 millimeter, and the stent which was placed was 3 millimeter. So what we did was we have now the confidence to take a bigger balloon because we have done an IVUS. So here we took a 4.5 millimeter NC balloon and approximately used a 5 millimeter NC balloon, and then we rechecked the IVUS. You could clearly see there's a significant improvement in the stent expansion after the IVUS and optimization with a higher or a larger NC balloon. Following this, we used a long magic touch, which is excellent sirolimus coated balloon, in fact, from India. And we had a great result. This was done almost 15 months ago, and patient is completely asymptomatic. If I had not done an IVUS, and if I had used a 3.5 millimeter or DCB, this patient would have come back with further restenosis. So intravascular imaging is very important, especially for restenotic lesions. Now, when would I go for another drug-eluting stent in this case? I would go for stent if I had a failed case of DCB. So by using both paclitaxel and sirolimus, if this patient keeps coming back with restenosis, and if the mechanical issue has been adequately addressed, and if there are no options available to open the native vessel, then I would go for a stent. So I'll just give you my brief algorithm for SVG stenosis. So if you have an SVG stenosis, you should ask yourself a question. Is it focal stenosis in a healthy looking vein graft? If the answer is no, please ignore the vein graft and treat the native vessel. If the answer is yes, then go for an angioplasty with a drug-eluting stent. Now, if the patient comes back with a restenosis, then again ask yourself a question, is there a chance of treating the native vessel? If the answer is yes, please go for that. If the answer is no, then do an intravascular imaging, could be IVUS or could be OCT, and then optimize the stent and then do a DCB. If patient has more stenosis in the future again, then either try a different DCB or go for a stent. This is my algorithm. Thank you. So my management option for this patient is treat the native vessel first as a first option. Second option is a DCB, and final option is a drug-eluting stent. Thank you. I'm open for any questions.
Do we keep questions in the end of the both the talks?
Yeah, yes, at the end of both the talks, yes.
Right. So Dr. Amol, if you want to have some comment?
No, I think we'll have a discussion after both the talks.
Right. So Professor Mohit Gupta, it's your turn to talk about this case. What would you like to have, please? Professor Gupta, you need to unmute yourself.
Thank you, Dr. Kamal and CARDIOCON team for a great opportunity. And thank you, Sandeep, for a terrific talk. Had I been given the same topic that you have been given, I would have been presented the same way. And I'll tell you, there is a reason for this. Why? Because when nothing is sure, everything is possible. And today we work only on evidences. And definitely, this is one of the conditions that intervention cardiologist is always in a dilemma. What do? You know, you are fighting like between a David and a Goliath, and guidelines are not there to guide you. So having this thing in my mind, this is the problem statement that you have very nicely given. Elderly male, territory viable. I'm not going to go further into the detail. One thing is sure, we have to intervene. I totally resonate with you that if I am given an opportunity, I will always go for a native artery open. There is no doubt about it. There is nothing better than that. But what happens when I don't have an option? Then you have to really understand that you are driving on a rough terrain. This is a very terrible terrain to drive on. And you really have to be very sharp, equipped when there is no evidence, and you have to come out with an ideas, and you have to come out with different opportunities and your own mechanism. And that is what I'm going to show you today. So let us understand, what are we intervening in? We are intervening in an SVG, different from a native coronary artery. Three things one should remember always: high atherosclerosis, very, very high inflammation, and almost 10 times higher chance of a thrombosis. This is what defines SVG. And why? Because the lesions here are more fibrotic because of SMC proliferation, and they are very less calcific. Remember, SVC does not has a media which is normal. It is a much thinner media. And I totally resonate with Sandeep when he says that it is more susceptible to mechanical damage by stents and balloons, as is very nicely shown by the imaging. And when you employ a drug-eluting stent, delayed healing, less endothelialization, and more uncovered strut, again, which was very beautifully shown by Sandeep. But does that answer a question? No. This is how SVG is working. Endothelial damage to a vein graft, abnormal vein patterns. Remember, a simple vein is exposed to an arterial abnormal pressure. It leads to blood stasis, significant thrombosis. The first thing, it thromboses very fast. And then the process of neoatherosclerosis, more diffuse, concentric, and less calcification, again superimposed with more and more thrombosis. Look at this, more and more thrombosis. And then coupling that, vein graft does not have a muscular rear. So high arterial pressure leads to abnormal dilatation, luminal dilatation, and more neointermental hypoplasia and no remodeling. So what happens? The graft fails. The restenosis is very high, as was shown. You know, almost 15 to 20%, they are failing within a year, and 50% by 10 years. And our patient, which we are discussing, is falling in this substrate. Beyond 1 year, progressive atherosclerosis and progressive thrombosis. So what is the evidence? Let us talk about evidence and let us design our own strategy. What Sandeep shows, I almost resonate that. The fact file talking about the native SVG vessels won't help. We are talking about the restenosis in a SVG. Remember, restenosis is an SVG, not a native vessel. But what we have to corroborate and correlate the findings and evidence what we have for a native SVG. BMS is better than POVA. There is no doubt about this. Absolutely confirmed. So no question and no discussions about it. But when we talk about a BMS versus a DES in an SVG, the evidence is contradictory, and my friend Sandeep would definitely agree with me. Why? Because the ISR CABG trial, which was one of the initial trials, very big trial, showed initially within 1 year, the drug-eluting stents were superior. But when these results were published over 5 years, there was a significant late catch-up after 1 year, and the TLR rates in both the groups were practically similar. So, different trials of BMS and DES have shown contrasting results. Basket Savage showing that DES are behaving better, whereas the DIVA trial, a large trial, showing that DES is not doing better than a BMS in native SVG only. Remember, native SVG only. So, the meta-analysis summarized. Look at the contradiction that they are given. The first meta-analysis published by Patel and Deepak Bhatt, they showed that there is no significant difference in DES and BMS for mortality and all the events. Whereas another meta-analysis showed that DES in SVG is associated with a shorter lower MACE. But these differences are lost on follow-up. So we are really lost. And drug coating balloon is really exciting, But are we satisfied with the evidence and the guidelines that Sandeep showed very nicely? And I resonate with that. The drug coating balloons are working superior, beautifully in a native vessel. Is it enough? Let us see. Drug coating balloon avoids an instant approach. Very good. Perfect. I'm happy with that. Paclitaxel drug coating balloon is established, no doubt about it. But remember, in ISR, in only native coronaries. What about the therapeutic benefit of ISR in SVG? It is unclear. And I'll show you the evidence. Look at this trial. The only trial and evidence that is available till date. The SVG, which is a large trial, it showed that 25 SVGs which had instant restenosis. 7 instant restenosis in a bare metal stent and 18 instant restenosis in a drug-eluting stent. They were all treated keeping the same hypothesis that DCB will be better. And when on median follow-up of 12 months, they examined the binary restenosis as well as the TLR. What was the result? It was eye-opening. The TLR was 72% when DCB was used in drug-eluting stents. When the DCB was used in bare metal stents, the TLR was only 14%. So 70% chances of high restenosis and DCB failure when a stenosis is occurring in a DES which is deployed in a SVG. Are you happy with it? I'm not going to buy it in this condition. But it was only 14% when a DCB is being used in a BMS. What are the reasons? They are not clear, probably different vessel architecture, different wall architecture, other mechanisms. So what are the current options? Current options is native artery. I am totally for it. Reduce CABG, not a question in this perspective because our patient is a perfect case of a PCI. Should we use a POBA or DEB? DEB is a good choice, but it is marred with a high restenosis. Almost 70% restenosis with the only evidence that we have. And that is very convincing. And if we use a DES, again, this is also not a very comfortable, but very high peri-procedural events, undeployed struts, multiple problems are there. So how would I define my strategy in this particular condition? How would I resonate with this particular strategy in this particular condition? My strategy would be very, very simple. SVG restenosis, if the ISR is occurring in a BMS, use a DEB. Why? Because it avoids the extra metal and we have a reasonable evidence to show that restenosis will be less when you are using a DEB in a ISR in a BMS. I am totally with Sandeep on that. But if the ISR is occurring in DES, imaging has to be used preferably in all the cases. Absolutely.
Hello. Sir, time is up.
Yeah, absolutely with one bit. But DES is a better choice when ISR is occurring in a DES, and DEB in ISR and DES is shown to have a very high restenosis. So my message to you is all modalities should be used wisely with a clinical experience. Why? Because a fool with a tool is still a fool. So I'm open to any discussion and questions.
Yeah, perfectly conveyed your message, Professor Gupta and Dr. Sandeep. House is open for question and answer. I'll invite the moderators for the session, Dr. Rushikesh, Dr. Jayesh, and Dr. Giri, along with all the participants. House is open for Q&A.
I completely agree, just to initiate the discussion with both the speakers, in the sense that there is no data for such kind of a case. I think you have to live out of the box. You have to probably innovate or maybe take a call depending on ischemia. I think the most important point that I wanted to ensure is to look at the viability first. Maybe you're looking at a scarred territory and you may actually not require any intervention, which Dr. Mohit was actually pretty aggressive about. And, I completely agree with that. So once a viable territory and once another, again, you have a restenosis and a patent LIMA, is actually probably individualizing the case. My question to Dr. Sandeep, do you think that there is data for the vein grafts per se in restenosis I know Dr. Sandeep has been using huge amount of DBs, I think 5,000 plus or 500 plus. I might be missing a couple of zeros, but how many of them have been in like ISRs in vein grafts?
Thanks, Kamal, for the question. I think it's a great presentation by Mohit. Look, we are dealing with a scenario where there's a very, very little data. In fact, Mohit showed the paper of a very small number of patients. So in my practice, as I said, we have almost refrained away from stenting the vein graft, especially if it's already restenosed once. So we tend to mainly go for the native vessel. And if I do want to treat a restenosis, it's a very small number. I always do a intravascular imaging, either OCT or because I need to address the mechanical issue. Because if you don't address the mechanical issue, no matter what you do, whether you put a bare metal stent, drug-eluting stent, or a DCB, they keep coming back. And the other thing which I've done in the last few years is that I just don't put a DCB after an NC balloon dilatation. I use a cutting balloon or a scoring balloon to insert some scar or some cuts in the intima or a hyperplastic region before I use a DCB, because it increases the uptake of the drug. So as I said, look, there is no strong data to support either of the strategy. Yeah. But going by the native vessel and the case I've shown where people have significantly underestimated the size of the circumflex, same thing will happen to the vein graft, because vein grafts usually are ectatic. And even if you put a 5 millimeter stent, it may be still small. So you still have to use an intravascular ultrasound, and maybe you take a 5.5 or a 6 millimeter NC balloon before you use a DCB or even a stent if you want to. So if you address a mechanical problem, then we tend to minimize the risk of further restenosis in the future. Do you agree, Mohit, with this?
I totally agree with you. And if somebody, to be very candid with you, if somebody is asking my experience in SVG restenosis, I would say I have none. I have practically not seen or addressed a restenosis in an SVG. And I would be very happy to know the experience, and extensive data search, it showed only a small evidence. So I think native artery is always the best choice. I would always be happy to use any kind of technique, whether antegrade or a retro or different technique to open the native artery. But in case we are again, facing this kind of a situation, always avoid putting a metal. That is very, very important, because these metals behave very erratically and poorly when you are dealing with a SVG. The endothelization is very poor. That is why only when, you don't have another option, like a DCB is failing very high in a ISR in a disc, then probably this could be an option. But what about you can just use a bare metal stent in a disc restenosis? That could also be an option, because you're not giving another drug or another polymer into that. So all these things are debatable. All these things are a matter of opinion, because I don't think there is evidence, and I don't foresee any evidence coming in near future or trials being designed to address this particular issue.
In fact, maybe, when...
what do you think, Sandeep, could be an option that might be that laser could play some role in this? I was just thinking and quoting that Elka, is it possible that, people have used rota, people have used different techniques in SVG? So,
yeah, I mean, look, I've used a shockwave recently on a SVG. This was 6 months ago, I think. As I said, if whatever the mechanical issue, I want to address it first. It could be an under-expanded stent or an undersized stent, or a lot of calcium or a fibrotic lesion behind the stent where you can't expand it by the shockwave or a laser. Once you adequately optimize the stent, and then whatever you choose next is fine. Although I go more for DC because I want another layer of metal. But I agree with you. We are dealing with a very unique situation. In fact, while I'm preparing this presentation for the CARDIOCON and Kamal's conference, I thought maybe we can collaborate, and I can look at last 5 years data in our center where we have treated the ISR with the SVG and try and see what are the options we have taken and see the outcome. I'm sure it's a retrospective analysis. We can probably do it. Maybe if you are up for it, I'm happy to collaborate. And so has Kamal.
Fantastic.
And Sandeep, what was your experience with the drug-eluting balloon in these type of cases, your personal experience?
I mean, as I said, I can't say I've not had patients coming back. So patients have come back 6 months later, 1 year, even with the DCB. So what I tend to do is I switch the balloons. Like if I've used a sirolimus, maybe I use a paclitaxel. If I use a paclitaxel, I use a sirolimus. I mean, there is again no head-to-head comparison between the two, especially for these kind of situations. So my experience with the DCB has been quite enormous, as Kamal mentioned, because 25 to 30% of my cases are with the DCB. because I want to avoid stent in certain lesion subset like small vessels, diffuse long lesions, ostial side branches, and restenotic lesions. So yes, so we are using quite a lot of DCB, but the use of DCB in a vein graft restenosis is very, very small because we tend to address the native vessel as soon as we see a restenosis. The only time we do is we don't have an option to open the native vessel either because of anatomical problem or any other issues.
Okay.
Sir, my question to Dr. Sandeep.
Mm-hmm.
Yes, sir.
Yeah.
Sir, is there any experience of using new generation thin strut bioresorbable scaffold in ISR, particularly in SBG graft lesions?
That's a good point, actually. I mean, again, these are all hypothesis generating ideas because we don't have data. But what you're saying is that you're giving a scaffolding for maybe 18 months or 2 years and then it goes away. So maybe it will work. Yeah, I mean, whatever you do, I think if the mechanical issue is addressed, I think maybe you can try absorbable scaffolds.
I would also like to add in that, Sandeep, that, you know, Sahu, you know, one of the major concerns with this particular scaffolds is that the high thrombosis rate, and you are already working in a very high thrombogenic milieu. So using a scaffold which already has a very high thrombotic chances in implanting in something that is already having 10 times higher thrombosis rate would not be probably a wise choice. And that is why it could be, you could be having some case reports, though I have not come across that. And that is why I avoided mentioning it. But this does not look to be very appealing or exciting to me in a practical way.
See, the other also, you have to understand, there are some papers which have shown use of covered stents in these kind of vein grafts. The reason is once you put a covered stent, you're basically isolating that area of thrombus behind the stents. So there are some data in the literature where there is a covered stent. But again, the numbers are too small to draw any significant conclusions.
Sir, one point, isn't that we should prefer using thin strut bioresorbable, particularly, thin strut stents or polymer free stents while deploying DES in DES?
Totally agree.
Yeah, I agree. I think if you're use the best DS available thinner struts. So you basically want to avoid inflammation. And polymer free, it's even better. So yeah, I agree with you. I think use the best DCB or DS you have in the shelf.
Yes.
Thank you. Yeah, probably imaging will also plays a, now it is readily available nowadays, so it will also play a great role in
definitely. Actually, it will also help us in understanding the pathophysiology and the exact mechanisms that are taking place, and we really look forward to have some good papers on that. We didn't get a chance to image one of them lately, but this is one of the things that will actually define and may change our practice and choices in the SVG ISR in the near future.
Yeah.
Yes, sir. Yes, sir.
Any other further questions, or we should?
Sir, time is up.
Yeah. Okay. Thanks everybody.
Thank you, everyone. Thank you. Dr.
Thanks,
Mohit,
Kamal.
Thank you so much.
Dr. Sandeep, and respected chairpersons.
Thank you. Thank you, Kamal.
Thank you, sir.
Thank you all for the invite. It's very nice to have.
Dr. Mania, Dr. Girish. Thank you very much.
Okay.